Okay, moving back over to digestion. We're going to pick up with starting with some chemical digestion. All right, in the mouth, easy, easy. Um, Two enzymes you'll notice here. Oh, before, well, we'll go ahead and do that. Two enzymes that you will see here, and they are um, lingual lipase and salivary amylase. Now, lipase breaks down lipids. That's all we're going to talk about. It's really an unimportant enzyme. There's another lipase that's much more important in another area, but there is a little bit of it going on in your mouth. The problem is that food doesn't stay in your mouth very long. It only stays in there 15 seconds or longer or less. And that's not really enough time to break down lipids. All right, but the main one is salivary amylase. Amyl always refers to starch. Starches are hundreds of glucose units attached. So in the 15 or so seconds that the food stays in your mouth, like if you eat a cracker, those big molecules of starch get broken down to maybe 12, 15 units of glucose. They're not quite, they're not as small as disaccharides or monosaccharides. They're a dozen and a half units of glucose, and they're called dextrins. And that's as far as it goes in the mouth, because then you swallow the food, it hits the stomach, and the acidity denatures the amylase. So you get a small amount of digestion in the mouth, just a partial breakdown of starch. You get chewing, physical digestion, that's easy. Okay, now, the picture you're looking at of this woman, notice there's a swelling right over here. Now remember, this is where the parotid glands are located, the big salivary glands. So if these become inflamed and infected with a virus, which is the mumps virus, you have mumps, which is also called parotitis. I got it when I was a kid because there was no measles, mumps, rubella vaccine, but you've probably all been vaccinated. Okay, moving on. Let's talk about teeth for just a minute. There are the four types. They have four different functions. Well, at least three different functions anyway. So look at your incisors right here. Now let's go. We're going to start. You're looking at the mandible. We're going to start from the midpoint right here. So look at these two guys, incisors. Kind of like for shoveling. In fact, they're kind of shovel, like spade shaped for like biting chunks like out of an apple. The food gets moved backward that way. So you next to it, you've got one tooth right there, which is a canine, or called a cuspid in humans. Now, if we were talking about a carnivore, we'd have some really great canines, but we don't. Ours are not that sharp, unless you're a vampire. Okay, then we've got a couple of premolars, or bicuspids, and we've got molars right here. Notice that there are three of them on this side. You should actually have another one here, but that one hasn't erupted yet. And these molars and premolars are for grinding. They're flat teeth, and they're for mushing vegetable matter, things like that. Now, if we start at the midway and we go from here that away and count the teeth, we have got two incisors, one cuspid, two premolars, and three molars. You have the same on this side as you do here, and on the upper jawbone you would have 2, 1, 2, 3 on each side. So remember, there are two incisors right here. If I asked you how many total incisors you've got in your mouth, assuming you have all your teeth, of your permanent teeth, you'd have 8. 2 times 4 quadrants. Now, that leads me to dentition patterns, which I just took you through. Permanent teeth, dentition pattern, 2, 1, 2, 3. There it is right there. Now, deciduous teeth. When you were a baby, you had milk teeth, or what are called baby teeth, and you lost them. Not important to know when they erupt or when they fall out, But you can see that they come in and out at different times. You have only 20 in a set, whereas you have 32 in the permanent teeth. The permanents are the ones you really need to know. Notice that there's one less molar and you don't have any premolars. For the permanent, there's one thing that's kind of important there, and that is these third molars. Notice that they don't come in until early adulthood, late teenage years. These are sometimes called wisdom teeth, and they are the ones that you very often get taken out, because by the time those guys come in, like these guys right there, all the rest of your teeth are in place, and there's no place for that wisdom tooth to fit in, and it crunches the other teeth, puts pressure on them, and that's bad, so they're taken out. Now, the views that you're looking at over here on the left, kind of like this view, it's showing you an erupting molar coming in. This is blood flow. So let's talk about how new teeth come in. Let me get to the next shot. Oh, the view you're looking at the bottom right, I just like this because it shows you all of the unerupted teeth sitting there waiting to come in and push those other boys out. Okay, so here's a look. The tooth eruption is complex, and there are many different ideas contributing factors to eruption of the teeth, but I kind of like this one. So notice you've got a tooth coming in right here, and the root, let me point out, this is crown above the red line and root below. Notice the crown is the first thing developing here, and here's the beginning of the root developing right here, and the root gets longer and longer, and as that root gets longer, the whole tooth is pushing upward. Now notice the baby tooth that's sitting right up there, and it gets shoved out of place. Remember that the blood supply to that little deciduous tooth or milk tooth, the blood supply is reduced because the vessels become constricted. The pulp in the pulp cavity dies. That's where all the nutrients and important things going on in the tooth, and it dies, and the other one gets pushed up into place. Now I mentioned that they're called deciduous teeth, the baby teeth or the milk teeth. And the word deciduous means to shed, like deciduous trees are the ones who shed their leaves in the fall. That might help you to remember the teeth that are shed. Okay, tooth structure. You're going to see these more in lab. I'm going to just hit some of these. Most of them are pretty easily identifiable. There's pulp cavity right there. Now the pulp is gone. This is a tooth that's been taken out or fallen out, and they stained it to show you enamel out here, and then the dentine, which is the mass of the tooth, and the pulp has died. That's where your living material is right there. By the way, tooth formation, the dentine formation, as in dentine gun, by the way, no relationship, but anyway, is formed very much like bone is. Now remember that the tooth is sitting in a socket, or an alveolus, it's called a socket, in the jawbone, upper and lower. So you've got bone on dentine, basically bone on bone, and you have odontoblasts instead of osteoblasts. Now, a couple things I want to mention here. What's holding the tooth in place? Well, two things. One, cementum. Look at the green stuff there. It's kind of like exactly what it says, kind of a glue-like filler material that helps to hold the tooth in. Then, more important, is periodontal ligament. Remember back in joints, gomphoses? It's the joint between the tooth and the mandible or maxilla. So this is bone here, and here is your tooth here. This is a joint. It's called gomphosis. It's a type of fibrous joint. And remember, fibrous joints, fibers holding the tooth to the bone here, and it's those little ligaments right there that are the fibers. They're very short little fibers holding it down in there. Got a good view of the root canal that the blood vessels and the nerves and so on go in and out of, and of course root canal work is something you'd rather not have. Okay, so let me go on here. Dental disease. I want to show you two things here. So remember, yellow is enamel and white is dentine, and pulp is this stuff right in there. There's your root canal down at the bottom. Okay, so remember you got bacteria all over the place. By the way, just want to show you also, here's your bone right in here. Up at the top here is gingiva, gum. Holds your tooth snug into the jawbone, kind of forming a tight, trying to think, like a belt, I guess, kind of holding the tooth a little bit more firmly. And of course above that is the crown and below it is the root. Alright, so let's talk gingivitis, which is obvious, so I'm not going to go into that. So dental caries, that's where I want to get to. Alright, so you have bacteria all over the place, in saliva, on your teeth. They particularly like to get right down here into those little spaces, which is a problem because that's hard to floss and it's hard to brush in. Okay, so the bacteria will get down in here and they'll form a hardened material called plaque. We'll get back to that in just a minute. Hard to get rid of. Also, the bacteria can get into those little spaces. Remember I showed you a picture a minute ago? Let me go back to that for a second. And notice, well, there we go. On this real tooth, you see all those like crevices and things like that, and they're great little hiding places for the bacteria. And they get in these little depressions, and they cover themselves with gooey material, and that forms plaque. Oops, by the way, I meant that to be a Q, plaque, not plague. And now they are covered by plaque, which is a hard stuff that protects them and allows them to have free reign. So what they're going to do is they're going to make acid, because that's a byproduct of cell metabolism, and that's basically how you get a cavity or a dental carie. Now, this carie can work its way down into the pulp, which now is going to cause you a heck of a lot of pain, and it can actually go down this way, which is really going to cause damage to the entire tooth, and you're going to have it out. Or you're going to, at the very least, have root canal work. And if that infection gets down here into the bone, then you've got real serious problems called osteomyelitis. Now, look at the pic down here. Looks like their teeth are longer than normal. It's not. Look at the gum. The gum has receded. So remember that plaque I was talking about over here? It gets into these little crevices. The bacteria get in here, and they start setting up a gingivitis, and the whole gingiva begins to kind of recede and pull away, and now your teeth don't fit as snugly. They don't look good either, and that causes them to become kind of rocky and perhaps fall out. That's called periodontal disease, and now you're talking serious, because if you don't get that nipped in the bud early, then you're going to have to get false teeth, or at least new teeth, some new teeth. Okay, so let's move on down the pharynx. We're now in the throat. I've already talked about upper and lower esophagus, and I don't think there's anything much to say about that. Okay, so smooth versus skeletal muscle. Skeletal, up towards the top, off the screen, and smooth muscle all down in here. So remember I said once you start the swallowing process, it becomes involuntary. That's because of this smooth muscle down in here. Now, look at this area right here. There's kind of a closure. It's called the gastroesophageal sphincter. Remember that. We're going to talk about it later. Okay, swallowing. Let's go swallow. You got a swallowing center. It's in your medulla. By the way, the proper name for swallowing is called deglutition. There are a couple of nerves involved, 5 trigeminal and 9 glossopharyngeal. We are going to move the food that has been chewed up and has been turned into like a toothpastey-like mess that's indistinguishable from anything you just swallowed or ate, put into your mouth. And that's called a bolus. In fact, they use the word bolus for like meaning a mass. Okay. So let me get over to a picture I want to show you, glutition. There we go. Alright, so look what's going to happen. There's the bolus in green. Let me take you through some things that are going to happen here. Your tongue is sitting right here. It's going to get shoved upward. You might even try that now. You'll notice the tongue moves up. You got your mouth closed, so where is this bolus going to go? It can't come out the front. It's got to go back towards the back, which is your pharynx or your throat. Now, we're now at the back, and there are two ways to go. Up into the nasal cavity, which, as you know, is not going to be very great. So we want it to go down. So in order to force it to go down and to keep anything from going into your nasal cavity, the uvula, which is part of the soft palate, is going to get pushed up to the back of your pharynx. Okay, so think about what's going on. Your tongue has closed off the oral cavity. The food can't come forward. The uvula is pressed up against the back of the pharynx. The food can't go up. There's only one place for it to go, down. Now, remember respiratory passageway, esophagus to the digestive system. You don't want this food to go down in here. So, notice right here, there's your epiglottis, it's labeled. The food, the bolus, as it comes down, causes the epiglottis, which is elastic cartilage, is very bendable, to fold down over the opening of the larynx, and the bolus is going to go down the esophagus. So again, notice that the epiglottis right there. By the way, your whole larynx moves up when you swallow. Remember that the epiglottis has no muscle. It's not opening and closing and going down and coming up by itself. It's simply a passive push down by a combination of the bolus folding it over and your larynx pushing up. Okay, whoa, that is not where I wanted to go. Somehow I have ended up going way too far. Let me jump. It's taken too long to get out of there. Okay, so let me introduce you to the stomach now. Okay, so now we're moving the food down in the stomach. Remember that gastroesophageal sphincter. Let me point it out again. It's going to be right inside there. It's not really a valve. Now you've got a real valve down here. You can see it. That is your pyloric sphincter. It's a round circular valve, and when it constricts, it closes tight. But that upper sphincter, sometimes also called the cardiac sphincter, by the way, is it's just really a constricted area. It's with a small lumen. That's going to become important when we talk about reflux disease. Okay, now if you look inside the stomach, there are these folds in there. It's called rugae. You'll see more of those. Actually, you can kind of see that rugae over here, this up, down, up, down. All right, sections. There are about 4 anatomical regions of the stomach. Now remember, your esophagus is going up like that. Your heart, I'm going to draw your heart. Wait, I drew it way too big, but you know that. Okay, so here's your heart sitting about like that, and your diaphragm is sitting right there. So your stomach is pushed up against it. Okay, so keep that in mind. All right, so the cardia region, this area right there, right below the heart. Fundus is this dome-shaped area right in here, fundus. Body, this area right in here, that's where most of the digestion is going on, along with the pylorus, which is this portion right there. And there, of course, is the pyloric valve. Okay. The view you're looking at down here at the bottom is a color-enhanced X-ray. The person has drunk an opaque dye, like if you drank Pepto-Bismol or milk of magnesia, they give you a dye, barium dye. And it coats the stomach, because otherwise the stomach doesn't come out in an X-ray very well. It's a soft organ with not very dense tissue. So you can see the stuff coming down through the esophagus. You can actually see that peristaltic action, and there's your fluid or whatever it is right there. Okay. Let me point out the beginning of the small intestine right there, going down this way. That's the duodenum. Okay, so why doesn't the stomach digest itself? Because there's a lot of acidity in there, obviously. So look at the picture up here at the top, and notice a couple things. One of the things you may not notice, but I'll point out, is these cells, simple columnar, are very tightly attached to each other, much more than other places. So the acid that's up here inside the lumen of the stomach cannot sink into the little spaces here and cause erosion in the wall. That's one thing. Second thing is you've got a really thick mucus layer lining this area on the inside. It also impedes acid from getting to this layer. Now, what happens when the acid starts doing some damage here, along with the enzymes? That's going to be an ulcer. Okay, so let me show you the histology. I've already taken you through this, so really I don't think I'll go over it again, but you've got mucosa, submucosa, muscle, mucosa. Okay, so good view of histology up there at the top right. Gastric pits. This is all mucosa. Whoops. All mucosa that you see. I'm trying to get rid of the bar here. Menu bar. Alright. All of this is mucosa. And so if you follow this simple columnar, follow my pen mark, it comes down like this, and it goes up like this, and it goes down like this, and it goes up like this. And where these dips are, there are little openings right in here. Here's one. There's going to be one here. There's a mirror. You see one over here. Oops. Uh-oh. Just took me somewhere else. Go back. Well, I can't get back. Alright. I seem to be stuck. Okay, let me try it again. Alright. So anyway, looking down on those little openings, if you were looking down, the floor was the inside of the stomach. Look at these guys right here. They're called gastric pits. And again, they are these little areas that I showed you going down deep into the mucosa. And that's where all of along the necks, going down into those pits, that's where you're going to find all the secreting cells. The glands. I'm going to finish up the glands of the stomach, and then I'll stop here. Alright, let me take you to the glands. I've got a good picture right over here. Good view of gastric pits on the left. Point out the cells here. You got mucus cells here. Oops, let me go back. Alright, got mucus cells here. I've got two types of cells down here, dark purple and light purple. The light purple are called parietal cells, and parietal cells make two things. They make hydrochloric acid, we'll talk more about, and they make intrinsic factor, which we already talked about, in blood. It has to do with B12 absorption for red blood cell production. HCl has to do with the acidity to activate the enzymes, which we'll talk more about. Those are parietal cells. Now, the purple guys right here, they're called chief cells. Chief, meaning they're the most important. Well, what would the most important do? They would make the enzymes. We'll talk about the enzymes in just a second. Okay, so let me go back. That's not where I wanted to go either. And let me head back over to the stomach. Okay. So, I've already told you about the parietal cells. We'll talk more about that. Mucus cells, chief cells. Two enzymes we're going to need to talk about, pepsinogen and renin. They both break down protein. No carbs broken down in the stomach. A little bit of gastric lipase, negligible, as I said with the mouth. So we're talking protein digestion. Now, there's some endocrine cells in the wall of the stomach also. They make gastrin hormone. They're called G cells for gastrin. We'll talk more about what it does coming up. All of the exocrine glands that make stuff, the proteins, the HCl, mucus, all form gastric juice. Okay, so let me talk about HCl for a minute. Here you're looking at parietal cells. Okay, remember, light purple guys. These are the blue guys you see right here. There's one, there's one, there's one. Here's the inside of the stomach right here in yellow. All right, so, sorry, chemistry. These cells, I mentioned they made HCl. Well, I kind of lied. If HCl was made, it would destroy this cell. Cells can't make acid that potent. So what's going to happen is we're going to make it in a roundabout way. Now, remember out here, there's going to be blood vessels, right? So remember a formula that I've mentioned before in respiratory system. Has to do with CO2 combining with water, forming carbonic acid, and then eventually forming bicarbonate. You see the bicarbonate right over there? It's kind of to the right of the screen. Alright, so what we're going to do here is, remember that bicarbonate goes out into the blood and it's going to be a buffer in the plasma for pH. And you remember that chloride shift that comes in to compensate for negative charged ions? The chloride is going to come in from the blood. It's going to go into the cell. There's your chloride right there that we're going to hook up with hydrogen in just a second. Now remember that there's going to be hydrogen ion. So remember, let me point out the carbonic acid, H2CO3, that forms when you get water and CO2 together. And H2CO3 is unstable. It's an acid, and it splits into hydrogen ion and bicarbonate ion. Well, you know about the bicarb. I just talked about that. Look at that hydrogen ion right there. There it is. These two guys come together in just a second. They're actually going to be secreted separately. So, hydrogen ion goes out. Notice this is counter-transport. Potassium comes in at the same time, so the hydrogen ion goes out. There's a little protein channel carrier there. They're going opposite directions. Now the chloride is going to go out through a chloride channel. So now we've got the chloride out there, and we've got the hydrogen out there, and they come together, and that's where your acid is made. Now, acid is what contributes to erosion of the wall, along with the protein digesting enzymes. So there's a lot of money in blocking or reducing hydrochloric acid production, which will reduce the ulcer. So we've got a group of drugs called hydrogen proton pump inhibitors, and they are going to block this right there. If the hydrogen can't get out into the lumen, and there's only chlorine out there, you got no acid. That's the way Prilosec and Prevacid work. Then you've got Pepsid, which is a histamine blocker. You know histamine in the inflammatory reaction, but histamine is also a neurotransmitter, and it's part of the parasympathetic autonomic nervous system neurotransmitters. And if it's inhibited, will reduce the secretion of hydrogen ion and chlorine. Alright, so I've taken you through this already. Look down here at the parietal cells. There is that formula took you through. There's the hydrogen ion that's going to go out into the lumen and is going to react with chloride to form HCl. And there is your bicarbonate that's going to go into the blood to be a pH buffer. Intrinsic factor, remember, B12 absorption. Okay, enzymes, real briefly. I mentioned lipase, really very unimportant. These two, important, protein. So let's talk about the enzymes themselves. All right, gastric lipase, unimportant, just like lingual lipase in the mouth. The ones I have circled here are the two protein digesting enzymes. Let me go pepsin first. Pepsin is a protein digesting enzyme, breaks down all proteins. It's actually made in an inactive form called pepsinogen. You've seen inogen before. I mentioned it with the clotting proteins. It means inactive. Pepsinogen gets activated. One of its side chains gets cleaved, and it becomes the active pepsin. You know what does that? It is hydrochloric acid. That's the role of hydrochloric acid. It activates pepsinogen. HCl does not break down food. Its job is to activate pepsinogen to pepsin, and it's the pepsin that breaks down protein in food. Now, there's one other little guy you see over here, renin. You don't have it now, but you had it when you were a baby. And the reason is that renin, by the way, this is R-E-N-N-I-N, not R-E-N-I-N. R-E-N-I-N, we covered in the cardiovascular system. You're going to see it in the kidney. Has to do with blood pressure. Sorry, different renin. Two N's, one N. Get over it. Anyway, this renin breaks down casein milk protein. And when you were a baby, and all baby mammals for that matter, they ingest only milk protein, and you have a special enzyme for that. After infancy, you don't make it anymore. We're talking about maybe a half of a gallon of gastric juice every day. Okay, so let me stop there. We'll pick up with gastric control of secretions later.